Bhumibol Adulyadej was born on December 5, 1927. He ascended to the throne as King Rama IX of Chakri dynasty at the age of 18 on June 9, 1946. His initial announcement as king was, "We shall reign in righteousness for the benefits and happiness of the Siamese people." In 1970, His Majesty asked his dentist after a treatment if there were dentists to care for villagers in remote areas. For people in poverty with dental problems, to stop farming and travel to see a dentist is difficult. In contrary, if the service is delivered to the people, it can be an alternative solution to such problem. With King Rama IX's royal remarks, His Majesty the King's Dental Service Unit was established. His Majesty has also granted a vehicle as a mobile dental unit. His Majesty the King's Dental Service Unit began its first mobile dental service on April 19, 1970. The unit has been providing dental services to people under poverty and the underprivileged for over 47 years up until today. The Dentistry Division, Anantamahidon Foundation. In 1955, His Majesty King Rama IX founded a scholarship program to support experts in different fields to study abroad, in order to apply the knowledge and technology to help develop Thailand. The scholarship was named Anantamahidon Scholarship. The Dentistry Division was granted Anantamahidon Scholarship on September 25, 1993. His Majesty advised his dentists that research is important. Dentists should be multidisciplinary. Not only should they care for patients, they should also be able to conduct research and invent medical devices for dental practices. His Majesty's words led to his endorsement on the establishment of Dental Innovation Foundation under royal patronage on November 11, 2009, within His Majesty the King's Dental Service Unit, with the mission of research and development in the field of dentistry towards finding preventions, treatment, and rehabilitation of dental problems for the people. Their key missions include 1. The dissemination of King Rama IX's empathy towards his people on dental health. 2. Research and development in the field of dentistry towards qualified innovations to meet international standards, leading to effective prevention, treatment, and rehabilitation of dental problems. 3. The promotion of dental healthcare services by His Majesty the King's Dental Service Unit, together with partners and networks, utilizing innovations developed domestically. 4. Organizational development to increase capacity in the invention of innovations towards continuity and sustainability. During the first phase of research and development, the Foundation placed emphasis on several oral diseases in the elderly, such as oral cancer. Oral cancer patients suffer tremendously as they are unable to eat and must be fed via a feeding tube. Patients also risk infection and pain when the tube is inserted into the throat. Dental Innovation Foundation, under royal patronage, partnered with the dentistry program under Anantamahidon Scholarship. Assistant Professor Dr. Arunwan Lam Ubon and Assistant Professor Dr. Dunyaporn Trachu Tham. Dentists who had been granted Anantamahidon scholarships to study in the United States of America to major in oral cancer and other related fields of study have led the research and development team to find solutions to these issues. The partnership had led to an innovative research and development project on food for oral cancer patients. The success of this project was a food product that allowed oral cancer patients to eat and not having to use a feeding tube. It was called NutriJelly. In the second sub-project, NutriJelly was further developed to add anti-neoplastic agents for oral cancer. This has better benefited the patients, providing them a higher chance to be cured. Another problem that occurred in older patients and oral cancer patients treated with chemotherapy was salivary gland disorder, causing dry mouth and insufficient saliva production. The two dentists researched and experimented until they could develop artificial saliva to solve the problem for such patients. This innovation is called moisturizing jelly. Furthermore, the foundation invented medical devices to help prevent dental decay and root caries, resin pit and fissure sealants, as well as fluoride varnish.
สำหรับที่มาของอาคารปฏิบัติการหน่วยทันตกรรมพระราชทานในพระบาทสมเด็จพระเจ้าอยู่หัวนะครับแล้วก็โรงงานที่ใช้ในการติดตั้งเครื่องจักรและผลิตนะครับเกิดจากที่ปัญหาของกระบวนการวิจัยและพัฒนาของมูลนิธิทันตนวัตกรรมในพระบรมราชูปถัมภ์นะครับปกติแล้วเนี่ยเวลาที่เราผลิตเราทำวิจัยและพัฒนาแล้วเนี่ยเราจะผลิตต้นแบบออกมาเพื่อทดลองทดสอบนะครับก่อนที่มูลที่จะย้ายมาอยู่ที่นี่เนี่ยอยู่ที่ทันตจุฬาคณะทันตแพทยศาสตร์จุฬาลงกรณ์มหาวิทยาลัยเราก็จะไปใช้ห้องแลบของมหาวิทยาลัยอื่นๆก็ไปเข้าคิวเพื่อที่จะผลิตในระดับเล็กแล้วไปทดสอบปัญหานี้เป็นปัญหาสำคัญเพราะว่าจะทำให้นวัตกรรมเนี่ยไม่สามารถที่จะนำไปสู่ประชาชนได้นะครับด้วยปัญหานี้เนี่ยในฐานะเลขาธิการมูลนิธิก็เลยนำเสนอปัญหานี้ต่อคณะกรรมการมูลนิธินะครับขอที่จะจัดหา facility เพื่อที่จะผลิตนะครับนวัตกรรมต้นแบบพร้อมกับกระบวนการทดลองทดสอบผลิตภัณฑ์ให้ได้นะครับก็เขียนโครงการขึ้นไปคณะกรรมการมูลนิธิก็เห็นชอบแล้วก็ของ
สวัสดีครับ Good evening everyone. Welcome to the fourth online webinar of King Rama IX Dental Implant Development Center Study Club. And today is our honor to have Professor Larry Cunningham with us in the lecture of the current management of the craniomaxillofacial trauma. First of all, may I introduce Professor Cunningham. He is the chair of the oral and maxillofacial surgery, and currently he is also associate dean of the hospital affairs in University of Pittsburgh. Professor Cunningham has a broad clinical interest in the maxillofacial surgery. He has a national recognized expertise in the management of traumatic facial injury. Professor Cunningham frequently lectures on the management of injury to the nerve that innervate the lower lip and tongue, and has provided surgical service to these patients for over 10 years. Professor Cunningham also enjoys as part of his clinical practice, especially the surgical management of patients with temporomandibular joint disease, including the total joint replacement. His research interest has including the bioengineering and resorbable allogenic grafting materials, craniofacial trauma and reconstructions, and inflammatory mediator associated with oral disease. He has over 50 publications in peer-reviewed journals. He is immediate past president of the American Board of Oral and Maxillofacial Surgeons as well as a member of the AO Craniomaxillofacial Surgery Education Board, which is an organization dedicated to education surgeons in the discipline of the facial trauma. Please welcome him, Professor Cunningham.
Thank you very much. It's a pleasure to be able to be with you all virtually today, and it's an honor to be invited to speak to your very prestigious group there. I'm going to be talking about current management of craniofacial trauma, particularly with regard to current technology and how it helps us perform better for our patients. You've, I guess, already heard my disclosures. I'll give a disclosure statement. I am a member of the AOCMF North American Board of Directors. I'm the chair of the Education Committee, and in that role I oversee much of the education for the Facial Trauma Foundation's work here in the United States. I'm unpaid in that position, but when I travel for the board, I do get reimbursed for travel. We try and make these lectures free of commercial interests, but I do have two companies that I'll talk about later in the lecture. I don't work for either company or get paid by anybody, but they're sort of the two that are involved, that I know about, that are involved in virtual reality work. So today our conversation will be to review current management of facial trauma and to discuss the technology that helps us improve our outcomes. And I start with a case that was done before I had the opportunity to use any of the current technology. Beautiful patient who comes in after having been thrown off the back of an all-terrain vehicle, a three-wheeler back in that time. And she obviously has a telecanthus, a large laceration there above her right eye. And we can just quickly go through the CT scans, but we see she has, significant right orbital floor and medial orbital wall fracture on the right, as well as a nasal fracture there, an NOE fracture. When we look at the axials, we also see the mandible fracture, but we'll kind of concentrate on the orbit there and the large fracture into the medial F-point sinuses. So if we look at it in 3D and we decide to go through her list, she has a mandible fracture with symphysis and a large dentoalveolar component there in the front. Lafort 1 fracture, bilateral zygoma fractures, the right orbital fracture that included the NOE component, medial wall and orbital floor, and then the nasal fractures. And so we go through kind of a normal thing. This is an older case, but still it's how we would treat somebody with these bad injuries. We would place the patient in intermaxillary fixation. We would repair the Lafort 1, the zygoma, and the nasal bone fractures. Kind of a regular way to do that would be to take a bone graft and to place it on the nasal dorsum, because she had significant septal injury and loss of a nasal projection. And you can see here before and after the placement of that bone graft. And our postoperative CTs at that time were obtained that evening or the day after. And we can see obvious problems here. And I don't suppose that we need the red line to show us where it is. But you can see that the medial plate was up inside the orbit, not against the medial wall, and actually lateral to the medial rectus muscle. So obviously this is not something that can be left. The patient did have another surgery or two surgeries on that right orbit, and 2 years later we're left with this result. Now it's not horrible, but it's obviously not normal, and there is an obvious medial canthal detachment that was not able to be retrieved. And the story on this was that this was actually much better reduced, but we had to go back into the orbit to remove the bone plate and to do a revision. And at the time of that revision surgery, this was the result after the revision. And I can't help but think if I had had the opportunity to replace that bone plate or to know where that orbital plate was before we left the operating room, that I would have had a much better outcome for this patient in the long term. So, you know, management of these complex fractures is difficult the first time you do it, but it's much more difficult if you have to do a revision. And so our goals continue to be and have always been with the management of trauma in general and facial trauma in particular, to obtain optimal form, to return the patient to optimal function as soon as possible, and to deal with the patient's expectations. And so what are the things that we use currently? These, you know, we use lots of computer modeling today in all of our areas of craniomaxillofacial surgery, TMJ, orthognathics, trauma, reconstruction, and intraoperative technology that includes navigation techniques as well as intraoperative CT scanning. Navigation is very interesting. It's used frequently, probably daily, by surgeons in otolaryngology, head and neck surgery, and neurosurgery, and probably other surgical specialties. But when we talk about intraoperative navigation, it's not unlike navigation that you get on your cell phone to find your way around a new town that you haven't ever driven in before. The unit is similar. For navigating around town, we have GPS, right? We have satellites. And the localizer intraoperatively is a control device that you see on the screen, and then I show another picture of on my next slide. The GPS device is similar to the surgical probe that we use intraoperatively to help show us where we are in space. And then the map, or you know, what we read from, is the CT database that's shown here and that you have preoperatively on the patient before you go to the operating room. And so this is a similar setup. The navigation unit is here, and this unit communicates with an array that is attached to the patient. In this particular case, we're showing an array that is secured to the patient's cranium so that the surgeon can move the patient's head, but all of the position of the bones of the face and the skull will remain stable to the array, so that when we look at it on the scanner, our scanner data, it's all the same. Now, it's important that this array be always have a straight line of sight to the navigation unit. And as long as these three balls on the tip of this array are able to be unobstructed to this unit, then we will be able to have successful navigation. So you'll see that this is an example of a wand that might be used in surgery and navigation. And the wand also has these fiduciary markers so that the surgeon can move the wand in space, and the wand and the array based on the patient's cranium both have to be unhindered to the unit. And as long as they are, you can use that wand to show yourself where you are in space. So the tip of the wand here is in the front of the orbit, but is not actually touching the patient, but that's where the tip of the wand would be, so that you can place that tip of that wand on the orbital floor and be able to see, are you in 3 dimensions where you want it to be? So that is the basics of the navigation. Intraoperative CT scanning has really been a wonderful opportunity for us to improve what we do in the operating room. There are a number of different companies that make intraoperative CT scanners. This is a Mobius O-ring. My institution actually has the C-arm for 3D rendering intraoperatively. This C-arm actually can be draped into the field. You can either drape it into the field and leave it, as they do in spine surgery, or more commonly for craniomaxillofacial surgery, we would put a secondary sterile drape on top of the patient and then bring in the C-arm to do a spin. It does show us 3D images immediately in the operating room. This takes about 15 to 20 minutes to obtain the view after you've called for the people, after you've called for radiology. This eliminates the need for postoperative imaging, and it does reduce the revision rate of surgery in the maxillofacial region. I particularly use the unit for orbital reconstruction. I think that's where much of the savings and the research has been in. I quote a recent paper here from 2020 that asked the question, does intraoperative computer tomography scanning in maxillofacial trauma surgery affect the revision rate? And indeed, in this study, there were 0 revision rates in over 20 patients when using the intraoperative scanning. So this has been a really giant step forward for us in maxillofacial surgery. This is an example of the use of it in the operating room. You can see the radiologists have brought in the C-arm. The patient is here with additional draping on top of the sterile field. And then everybody trying either wearing lead protection for themselves or staying 6 feet away from the unit. And underneath this drape is the patient's face. This C-arm has been aligned to the patient's head so that as we collect the image, we know that we're getting the entire area that we want to look at. The surgeon in this particular case has scrubbed out to take the pictures of the C-arm in use. So ordinarily the surgeon would be scrubbed in and observe the images, and then to be able to toggle through the images to see if your reduction of your bone plate was appropriate. The third area of technology that has been a giant step forward for us in the management of these complex injuries is patient-specific implants. And when you get, there are several companies that will make patient-specific implants for us. They are based on computer modeling, based on CT scanning, particularly useful for a very difficult orbital floor or medial orbital wall fracture when the patient's opposite side is uninjured. In those situations, the technicians can do a mirror image of the uninjured side to get what about as closely as you could get the anatomy of the injured side, so that they could mirror image that and make a floor plate or an orbital reconstruction plate for the injured side based on an uninjured mirror image. These are typically milled from titanium. They take 7 to 10 days to receive. And again, I feel like this is most useful in revision surgery, but anytime that you want to use them, you have to factor in the timing of having this plate custom made, and it is about a week before you'd be able to receive that. The computer modeling goes through volumetric changes and analysis. In this particular patient, the normal volume was approximately 28,000 cubic millimeters, and it was 30,000 cubic millimeters before the injury was repaired. But then once the orbital floor plate was designed, it's designed to try and equilibrate the volume of the orbit. And so after this design was complete, the injured side volume was 27, almost 28,000 cubic millimeters, and that was what the uninjured volume, almost equal to the uninjured volume. And here is the implant design being shown. So another clinical case, this is an image of a patient with a gunshot wound to the face. And our technology used for this particular patient was intraoperative CT scanning. This was an immediate repair, so we did not take time to wait for a custom-made plate. But here you can see the large orbital floor defect and the orbital rim defect. And this was repaired in a standard fashion with a plate at the orbital rim and an orbital floor plate positioning. And this was the first scan. And in sort of the middle area, it's not too bad, but in the second area, we see a different positioning. And in the sagittal view, there doesn't seem to be very much difference. But when you look at the coronal view, you see that the medial wall was not reconstructed appropriately, and that the orbital plate was actually in the orbit and medial to the lateral to the medial rectus. And in the second scan, you can see a much improved position. So this was a case of my own that solidified the importance of intraoperative CT scanning for me, because I have always had, prior to this, difficulty with this medial wall flange. But knowing that you have it in the right place when you leave the operating room gives you a much better sense of security and that the outcome is going to be what the patient needs. And a close-up of that image and where the plate was and where we wanted the plate to go. And then a close-up of that postoperative second positioning. So I have another patient that I would like to discuss with you that is a secondary revision of craniomaxillofacial surgery. And I think that this patient was repaired before the original surgeon had the opportunity to use some of the technology that we ended up using in her revision surgery. But she's a panfacial fracture from a car crash. And she has a pretty extensive problem list and has had multiple surgeries already before she presents to our clinic. She's got malunions of the zygoma and of the orbit. She has enophthalmos. She has not only enophthalmos, but hypoglobus. The entire orbit, the entire globe is low compared to the other side. She's got significant scarring. This scarring has led to significant epiphora or tearing, secondary to damage of the lacrimal system. She's significantly dissatisfied with her outcome of her previous 3 surgeries. And I came to see her because she was referred to the prosthodontist, and the prosthodontist couldn't seat a denture that he has made. And when we look up in the vestibule, we see that part of her reconstructive surgeries was to do a camouflage with a hydroxyapatite implant. And this implant had become exposed and chronically infected and was causing the patient an inability to wear a denture that's implant retaining. This patient had subsequently been referred for microvascular free flap reconstruction of this area, but did not know why she was getting a free flap. And the referring surgeon, I don't think really knew which direction to go at this point in time. So I saw her as a result of her being seen by the prosthodontist and was able to discuss some of her care with her. So this is a big problem. There are a lot of issues, and we at that time got a model of her skull printed so that we could study what the problems were and the malpositioning of the orbit and of the zygomatic bones. We got CT scans and 3D recons and SLA model. And at this point, we planned this patient for a zygomatic osteotomy because the primary problem was the malpositioning of the zygoma. We planned to use intraoperative navigation to help us achieve symmetry. And we also made comment in our notes that we wanted to ensure that we resuspended the soft tissues of the right malar eminence to help achieve facial symmetry and to correct some of her soft tissue ptosis. So in our studies, we note that the right zygomatic arch and eminence are significantly malpositioned. Our CT scan shows a orbital floor bone plate that is significantly down into the sinus and does not reconstruct the orbital anatomy at all. Intraoperatively, we are using a different kind of array that was shown previously, but this is Again, the array unit that would have been used, and she did have a cranially based fiducial markers for spatial positioning. This is intraoperatively, and as we discussed before, we could use the wand to help us position the malunion zygoma. This is actually how we would have used the wand. You can tell that we have repositioned this is the original position of the malunion. And in surgery, we have surgically repositioned this and are touching the tip of it with the wand. And we note that it has symmetry anterior posteriorly with the uninjured side. So the wand is on the malar eminence in its new position. And the horizontal line here shows us symmetry with the new position, or with the old uninjured position. Likewise, in the coronal view, we are touching the orbital floor and noting that we have a good horizontal symmetry in our new position. We have some intraoperative shots of our new hardware repositioning the zygoma, and an image here of a resuspension of our orbital fat pad. And that fat pad was secured to the lateral orbit with sutures coming here through our incisions. And you can see a significantly improved malar eminence and suspension of the fat pad here relative to the other uninjured side. And this is approximately 2 to 3 months post-operatively. She still obviously has some difficult scarring and epiphora here at the medial canthal region. We did not address that. At this particular point in time, we repositioned her zygomas and her zygoma and her orbital floor. And we were able to achieve what I believe is a very good result that would have been significantly more difficult without the opportunity to use navigation to know that we were positioning things in space where we wanted them to be positioned. And again, now the post-operative CT scan showing a much more appropriately reconstructed orbital floor and a before and after photo of the patient with a much improved malar eminence and fat pad positioning. Here I have another patient that has a post-operative. This patient is approximately 2 or 3 years post-op from open reduction internal fixation of mandible, zygoma, and orbit that show malunion of each of these areas. The mandible is wide. The patient has a significant malocclusion. She has enophthalmos, diplopia, and a bit of hypoglobus as well. Here's her occlusion that she has had for approximately 2 years and was unattended to until she came to finally visit our clinic. The technology that we used for this particular patient includes intraoperative CT scanning and patient-specific modeling and plate construction prior to surgery. This is how we go through, this is how I went through the planning for this patient. We can see that the mandible is wide and not correctly positioned. This is the small bone plate that was used at the time, perhaps in inadequate stabilization. We note that the zygomatic and lateral orbital rim component here was malpositioned and that the orbital floor is not well reconstructed. As we discussed these plans with the patient was less worried about the zygomatic positioning and more worried about the globe positioning and the mandible and the occlusion. So those were the things that were addressed for this patient. We can see here the repositioning of the mandible after we tried to reestablish as appropriate occlusion as possible. We will note that those teeth have shifted over the 2 years that nothing was an occlusion, and so this was not her perfect premorbid occlusion, but certainly she would be able to masticate and function with this. So you can see the new shape of the mandible here, and the from there we had a plate custom bent to this patient's mandible, so that we did not actually wait to bend the plate in the mandible. We had, in surgery, we had the plate pre-bent and sent to us from the vendor. This scan is showing or demonstrating the placement of our orbital floor plate that was custom. This particular component is designed to drill the holes in the specific place that we want them on the infraorbital rim, inferior orbital rim, so that when we place our patient-specific orbital floor plate, it will be in the exact position that we plan it, because we will use the screw holes that came on the template. And this is the design of the patient-specific or custom-made orbital floor plate. Again, you may wait up to 10 days to receive this implant. So it's not inconvenient when you're doing a revision surgery, because this patient had already waited for 2 years. So waiting another week or two for their implant was not inconvenient. So we go to surgery and we remove this original bone plate, do a osteotomy, place the patient in maxillomandibular fixation to achieve as good an occlusion as possible, and then put a much stronger piece of hardware that is load-bearing and that was pre-bent to the computer-generated shape of the new mandible. So the technologies used here were that we had a plate that was pre-bent to a patient-specific position. We used a patient-specific template to position our patient-specific custom-made orbital floor plate. And intraoperatively, we used navigation to ensure that the position of our bone plate was where we thought it was. And again, this is real time using a wand that's got the fiducial markers on it, and placing it on our reconstructed orbital wall and trying to see if we have achieved symmetry with the uninjured side. So in this particular area, we are putting the wand back on the platform of the bone, and we note that it is in a position where we want it, not down in the maxilla, but it is actually connecting with the posterior margin of the fracture. We see in this upper right-hand corner that the wand is on the new orbital floor. The picture that you're looking at is a pre-reconstruction picture, so it does not have the orbital floor in it yet, but the patient does, and the wand is touching the floor, and we note symmetry with a horizontal line with the other side of the uninjured side of the patient. And again, here we are checking our plate for symmetry with the medial orbital wall. We did go ahead and get post-operative CT scans on this patient to show that we have achieved a much improved orbital floor reconstruction, much improved symmetry, improved orbital floor in the sagittal view, and that we achieved it all the way back to the posterior fracture margin. Our postoperative CT scan shows a much improved symmetry of the mandible, as well as correct positioning of the condyles. And postoperatively, we have patient going through eye motions with no diplopia and no restrictions, and a much improved view or outcome of the position of the globes postoperatively. You can see we've really achieved a much better position of that globe and taken care of that enophthalmic look that the patient had previously. Again, we did not address the zygomatic position or the lateral orbital wall. The last part of technology that I would like to point out or bring up is, I think, what the future is, and we are looking at virtual reality for a number of things. Now, this is where I have a couple of vendors that you'll see their logos. But it is interesting to think about where we might go with virtual reality. I believe that planning could be an area where we do it, but certainly training of our residents and of our surgeons to do techniques that may be new to them or maybe new completely. I have quoted here an article on virtual reality training and how it improves training performance in total hip arthroplasty. This was a randomized control trial. They had equal numbers of residents who had not done a procedure before. Part of the residents learned it the normal way, where they went into the dry lab and did some stuff, and they read about the procedure, and then they went and tried to perform it. And the other group was taken through the performance of the surgery using virtual reality. And the group that learned how to do the case virtually before they went into the operating room showed decreased time and increased performance metrics. So this obviously wasn't in CMF yet. This was in orthopedic surgery. But certainly I believe that some of these will be coming along for craniomaxillofacial surgery in the future. This is me, and this was my first time that I was actually using virtual reality. This was I was just being exposed to it for the first time. This was not on a CMF patient, not one of my own patients, but I was just getting to really see what we think virtual reality can do. It is like playing a video game. It allows the user to be immersed in a 3D operating room. You look around the room and you see everything that's around you. It allows the user to interact with other users digitally. So I could have my colleague also with these goggles on and also with his instruments, and we could operate together in the virtual space. So you see virtual images and you see other users in the virtual space. This is a picture of what I was looking at when I was using those goggles and using those instruments. There are, I think, probably 8 or 10 different surgical training experiences that that J&J has now through Oculus. They are all for orthopedic surgery right now. But as you can see, I was practicing my skills at repairing an ankle fracture in that last video of me using the Oculus. But virtually, using your handheld device, you pick up these instruments and you are able to move the instruments virtually so that you actually see what instruments you use during the case. You are able to change that fluoroscopy unit and see that change in the operating room virtually. And so this is an exciting thing because our residents or surgeons who want to learn new techniques can practice virtually however many times they want. They will never, hurt or have a complication on a patient until they have practiced enough and feel comfortable with the steps of the process. Very exciting opportunities. That was J&J, and this is a second company that has been working with this that I have seen and actually used some of the models. It's called Immersive Touch. This is a software that allows the surgeon to segment out the areas of the bones that are in the malposition. And so the surgeon actually would create the segmentalized segments here, the green portion of the zygoma that includes the malar eminence and the lateral orbital rim, and the separate comminuted segment of the zygomatic arch. So you would actually do this yourself. And then you can use these same tools to reposition that arch to the exact position that you want. And then potentially have an orbital floor plate made or plates made specifically to the position that you have placed them. So the surgeon can do all of this. Now, whether or not the surgeon wants to spend time doing this or use a technician who's much more facile with the software, that's a good question. But this is available now today for surgeons to review, to use, and to actually pretend to do the surgery before they actually take the patient to the operating room. So again, this is a virtual reality, a picture of the person using the the handheld units, and then what that person is looking at. So the user then is repositioning the zygoma right where they want it, right where it goes, and they're able to check symmetry and move it in 3 dimensions of space until it's where you want it. Now, truly today, after you, the surgeon, have done that, you would probably kick it back to the vendor for a custom-made plate, for example, or a cutting guide, or something like that, and would likely benefit from using intraoperative CT scanning or navigation. But this, to me and in my practice, is not ready for prime time for surgical use, but certainly for resident training or for training new procedures for surgeons that are already practicing. This can be a very good adjunct because you really see in 3 dimensions what you need to do with the fracture segments for your reconstruction or the malunion segments. And then you can take that now more visceral knowledge, because you've been working with that patient's bones virtually, to the operating room and have a much more in-depth idea of the surgery that needs to be done and how you would treat that patient. So those are the things that I have to present with you today. I mean, technology really is helping us do much better work with our patients, either for reconstruction of post, malunions, or for the initial treatment for the primary reconstruction of the traumas. We have intraoperative techniques that include intraoperative CT scanning and intraoperative navigation that are now being used by many places as mainstream for craniofacial trauma, whereas both of those had primarily been used by neurosurgery and otolaryngology in the past. Patient-specific implants based on reforted pre-traumatic anatomy are a major improvement in the way that we treat patients, either from complicated primary traumas, when we know that we're going to wait 10 to 14 days to get a custom-made implant, but really has helped a lot with secondary revisions of malunions. And then we talked a little bit about virtual reality as a future adjunct to surgeon training and surgeon preparation, currently being taught with orthopedic surgery, but hopefully in the future with CMF surgery. As part of the AO, we put on a computer-aided maxillofacial surgery course. Our next course is in November in Tampa, Florida, and this is a course where we teach surgeons how to use this technology that we've been talking about: intraoperative scanning, intraoperative navigation, and custom-made plates. It may be that you have a availability to go to a course like this where you are. Hopefully you do. But I really think that this teaching in this course and using this technology is not only its current, how we're doing, but also for future use. I think we're going to be improving ourselves all the time through these technologies. So with that, I will open it up to questions, and I appreciate your time. Thank you very much for the opportunity to be with you this morning.
Thank you very much for your update and interesting lecture today. So let me check, is there any questions from the audience? So if there's no question, may I first start with the first questions. As you are working a lot with the facial trauma patients for a long time, do you find any decreasing of the cases or increasing of the cases, especially for the facial trauma? Since in Thailand we found the number of the trauma cases is decreasing due to the number of the government policy. So what is your opinion here?
Yes, sir. I think that we have seen that in the United States as well. We saw it. It's not changing as much now. I mean, the things that changed a lot of the trauma that we had in the early 2000s were mandatory seatbelt use, and then improvement in airbag use in our automobiles. So we see a lot less. I think we see a lot less frontal sinus trauma with airbags and seatbelts. Helmet laws, likewise, with helmets having to wear them on motorcycles and on bikes, decrease the amount of facial trauma that we see. But as in our place in Pittsburgh, where I am and where I was before in Kentucky, it seems to be stabilized out now for the past 5, 6, 7 years. It hasn't really changed the amount during that period of time. Now, in other parts of the world, I was at a meeting recently where they were presenting abstracts on facial trauma related scooters. And I'm not sure if you have these electric scooters where you are, but it's, you know, people get on it's like a skateboard that has a handle on it, but it's battery powered. So you just get on it, you turn the knob and you go. And it's young people that are using the scooters quite a bit, and they use them more in the evening and later into the night. And these papers that were presented were talking about intoxicated scooter drivers and the timing of those injuries and seeing a new thing. So so indeed, in some areas, we're seeing an increase in a different type of trauma related to motor vehicle injuries. But I agree with you. You know, overall, the safety things that we build into our cars have really decreased trauma that we see.
Thank you. So I saw from your lecture that there's a number of the patients that you show us is the secondary surgery. I mean, it's a defect from the trauma before, right? So what is the cost of that secondary defect? Why don't we can correct it from the first surgery?
Well, so I think that's an excellent question, and you know, when you have sometimes you have complications because you have hardware problems. I think some of these complications that I showed were related to my revision surgeries were related to the fact that the primary surgeon didn't do it right. So why didn't they do it right? And that's the question. And certainly, and I showed cases of my own where I tried to repair an orbit and I put the plate in the wrong place. And I think the key is that today you should never leave the operating room without knowing that the plates are in the right place. Now, one of the patients that I showed had inadequate hardware on the mandible fracture. I mean, the doctor just missed the mandible fracture. However, if you got a CT scan in the operating room after you do that repair, you might have said, you know what, I don't like the way it looks, it's not symmetric, and I need to redo something. So there are times when I think before we have technology, that we think we've done a good job and we just haven't. We just missed it. You can follow the principles and still get it wrong. It's easier to get it wrong if you don't follow the correct principles and don't use the correct stabilization. But you know, if you put the bones where they go and then you put the correct stabilization on there, and then you are able to check it immediately in the operating room, I think we have a much better chance of getting those patients properly treated, hopefully without malunions.
The reason why I asked you this question is because we also have found number of problems here in Thailand as well, especially for the refer cases to us that where the first surgeon cannot manage properly, and maybe there's some facility limitations in that hospital that they cannot properly finish all the job. So my next question is my interest with the navigation system. I have a few experience with the dental implant navigation system, which I think is almost the same principle. But unfortunately, we don't have the navigation system for the maxillofacial surgery at this moment. So I agree that this system can help and can be very good for the young surgeon to train, especially for the virtual reality, right? To train them to be a good surgeon in the future, and it's very, very interesting. My question is, from the beginning of the transition from the conventional technique to the navigation system, I think they need a lot of learning curve, right? For me, I spend many times with many cases until I get understand with the system. So from your experience, can you share with us that how fast or how difficult to start using the navigation system for the maxillofacial treatment?
I think that the units are, after you have an orientation to the unit, like the particular product that you have, I think that it's pretty intuitive once you get going, particularly if you have significant experience with navigation for dental implants, because then conceptually it's all the same. The instruments that you attach to the patient are not that complicated once you have used it. But I think an experienced surgeon can spend a couple of hours in orientation and practicing and then be able to use the units for things that I've described today.
So for those a doctor who doesn't have any experience with the navigation system, what do you recommend to start with or to train with?
Well, for example, if maybe you have a course that is like our computer-aided surgery course, where you're teaching a course to show people how to do it. If you didn't have a course like that, I think the first thing that I would do would be to ask an ENT colleague if you could observe them in surgery when they're doing sinus surgery. Because then you get just to see exactly how everything is done. If you don't have ENT colleagues using it, you might ask your neurosurgeon colleagues if you could see a case of navigation. Because I think once you have watched somebody do it, you would have an understanding of what is being done. You have to have expertise in reading CT scans of the face, and you have to have expertise at facial trauma reconstruction. But if you have those two things and you see a few cases being done, I think that you would be fine to go forward.
Thank you. So my next interest from your lecture is the 3D titanium implant design. This is I mean, it's very, very new in Thailand, I think. So how do you find the accuracy of those digital technology in terms of produce this kind of implant? Is it totally fit 100% or we need to adjust any part of the implant in order to adapt to the defect?
Yes, that's a good question. If for the times that I have used this for orbital reconstruction, I have never adapted the plate. I don't grind on the plate. The accuracy is very, very good, like within millimeters, half a millimeter. If you use patient-specific technology for other areas, for example, cranioplasty, you may not see a perfect fit among the entire defect, depending on the material that you use. Most of the vendors, when they mill titanium, the titanium is almost perfect every time. Other materials, there's a material called PEEK, polyethyl ethyl ketone, that many surgeons use for areas of facial reconstruction, particularly cranioplasty. And it does not always fit perfectly. And some of that's due to how long it's before it's used, and is there bony remodeling from the CT scan and issues like that. But sometimes those implants have to be modified a little bit. But for the maxillofacial area and titanium implants, they almost fit perfectly every time, in my experience.
And what is the important factors that can create or can help this kind of accuracy? For example, if you have any kind of CT scan can produce the good quality of the file, the DICOM file, or we need to adjust or to have to request for the specific CT scan. Do you have
Yes,
any?
that's a good question too. The finer cuts that you have, the better the outcome of the implant will be. So if your usual CT scan order is 2 millimeter cuts, that's probably not enough. You would want to get the best accuracy, you would want 0.75 millimeter cuts on your CT scans. You know, if the computer doesn't have enough information, you get volume averaging. And so then the computer model would fill in the blanks between the 2 millimeters. But for trauma, particularly in the orbital floor, that may cause the implant not to fit very well. So you need a fine cut CT. You know, with each of the vendors that I'm aware of that will make these custom plates for us, you sit down on a webinar, much like this, with a technician, and they will, you will help them design an implant. And that's important because the surgeon will know if the implant can go where they want it. Sometimes there are pretty large orbital fractures, and the technicians can make these orbital reconstructions in 2 pieces. For example, you could put one orbital implant on the medial wall and stabilize it, and then you could have a second implant that would come from the lateral and do the orbital floor. And they could interconnect somehow, but you don't have one giant implant that you're trying to put in through a transconjunctival incision. So the technicians are very good, and the more you work with the same person, the better the team becomes. But with regard to the CT scan, certainly fine cut CTs are important.
Thank you for your comment on this point, because we just start to do this kind of the customized titanium plate and cutting guide recently, and we found that the design of this kind of cutting guide and the titanium plate is quite tricky. I mean, if we design is too big, then we have to open our surgical site in order to put everything into the site or the defect. But Yeah, I agree that if we can design it separately, two pieces, and then construct and make it together in the operation field, maybe we can do the surgery with the minimal invasive way. Thank you very much for your comment and answer. So let me check whether is there any more questions. So there is a question from the floor that what is the name of the program you used to do the 3D implant, or you just order lab to do this for you?
So the implant is created from the particular vendor that you would use. So there are in the United States, you know, there are 3 of them that I know about. Synthes, Stryker, and well, those are the 2 that are at my hospital primarily. So, but you know, you probably have different companies that you work with in Thailand.
Synthes, you mean the ProPlan software, right?
Yeah, that's correct. Yeah.
So you do it by your own system, or you order this from the outside lab?
Yes. Order it from the company.
I see.
Yeah. Yeah, I would get on a webinar with a technician from the company, and then they would use the software. And then I would agree that I like the design of the implant, and then they print it and send it to me. Now the Immersive Touch, the one at the very end where the virtual reality, the surgeon was doing it itself, that I think is that may be a partner company with Stryker. But I would, I mean, technically you are ordering it from the lab, but it's from the company who's making the plates for you. And that's who I get on the webinar with.
So in United States, how long is take time for this kind of the system? I mean, from the first contact to the company and until you get the product, how long does it take?
Yeah. So if I see a patient in the clinic, we get a CT scan, and then we upload that CT scan to the technician, and then the technician will review the data, review the DICOM data, and see if there are any motion artifacts or any problems with the data. And then they will email me, usually the next day, to schedule a call, to schedule an online planning session. And then, however soon I can do that, maybe it's the next day, we design the implant. They fill out a report for me, send it to me the next day. I agree with the report, I say print it, and then I usually get it in about 10 days. If they are printing plastic for us or acrylic, you can get it in 3 days. But if it's milled titanium, it takes 10 to 14 days usually.
That's also very fast. Okay, let me check the question from the floor. Oh, there is one more question. In the intraoperative CT scan, navigation and PSI, is this the standard treatment in the United States nowadays?
It depends on what hospital you work in, and you obviously know that there are different levels of hospitals. I have been privileged now to work in 2 different hospitals that had intraoperative CTs. However, it took me a long time to get one at my previous institution. So I think if you have one in your institution, it should be, you should try and use it on every difficult case, on every, like a Zygoma Orbit, I think I try and use it on all of those. Patient-specific implants are not used on every case, because frankly, most of the time you can use a regular orbital floor plate and do fine. If you have to redo it, then you might think about something custom made. I think navigation is probably the least used in oral and maxillofacial surgery community, but probably a lot more used in ENT or otolaryngology because they use it all the time on everything. So I guess in order for my practice, the order that I would use things in: intraoperative CT, most common, navigation, and then custom-made implants.
Thank you very much. So I think that is all what the questions we have from our participant today. I would like to thank you, Professor Cunningham, for your honor lecture today. Thank you very much. And
thank you very much. It was my pleasure being with you. I appreciate it very much.
If you can share your email contact, then it might be very good for our participant to contact you directly if they have any other questions.
Yes, that'd be fine. I'll put it in the chat room.
Yeah. Thank you very much, and hope to see you in person in the future in Thailand.
I would love it. I can't wait.
Thank you. Bye bye.
Bye bye.
ครับโอเคก็สำหรับวันนี้ก็จบลงนะครับสำหรับออนไลน์เวบินาร์ครั้งที่4นะครับก็สำหรับปีนี้ก็น่าจะครบ4ครั้งเป็นที่เรียบร้อยนะครับสำหรับเมมเบอร์ยังเหลืออีกครั้งหนึ่งนะครับยังเหลืออีกครั้งหนึ่งนะก็เดี๋ยวติดตามข่าวสารจากทางชมรมนะครับซึ่งจะส่งไปให้ทุกท่านที่เป็นเมมเบอร์หรือท่านที่อยู่ใน Line Contact นะครับแล้วก็ปีหน้านะครับเราก็จะมีเรื่องดีๆให้กับทุกท่านได้รับชมรับฟังอีกนะครับรอฟังข่าวสารจากทางชมรมนะครับอีกทีหนึ่งครับวันนี้ก็ขอให้ทุกท่านนอนหลับฝันดีนะครับสวัสดีครับ